Hello friends, welcome back. Today I am going to discuss with you the global menace of multidrug resistant tuberculosis. Let me tell you some quick facts about tuberculosis. 1 out of every 4 people in the world is infected with tuberculosis. 2 billion people in the world carry tuberculosis bacillus in a latent form. 10% these people, or roughly 200 million, will develop active TB in their lifetimes when these latent forms become active. 1.5 million people die of tuberculosis each year in this world. This picture reminds us of the TB sanatoriums where people infected with tuberculosis were kept for self-healing in fresh air. There were no TB drugs available then. The 4 first-line drugs for TB were discovered later. Isoniazid and pyrazinamide in 1952. Ethambutol in 1961 and rifampicin in 1966. Things went well for some decades, but slowly, over the years, some of the TB strains became resistant to the first-line drugs because of the genetic mutations in the tubercle bacillus. Mutation in the RAPOB gene causes rifampicin resistance, and mutations in the CAT-G, INHA, AHPC genes results in isoniazid resistance. Mycobacterium tuberculosis has 7 genetic lineages. These lineages show variable transmission potential. Out of these, Beijing genotype deserves a special mention. It was first described in 1995, but it had a rapid worldwide spread and is currently responsible for 50% of TB in East Asia and 13% in rest of the world. This genotype shows escape from BCG vaccination, giving it a selection advantage over other genotypes. Also, Beijing genotype has developed multidrug resistance, giving it another selection advantage over other genotypes. This is also more virulent than other genotypes. Coming to the multidrug resistant TB, it is defined as a tuberculosis disease caused by a strain of M. tuberculosis complex that is resistant to both rifampicin and isoniazid. Another important term that you must know is XDR, which stands for extensive drug resistance. Pre-XDR tuberculosis is defined as any MDR strain that is also resistant to any of the fluoroquinolones. And finally, XDR tuberculosis is defined as any MDR strain that is resistant to any of the fluoroquinolones and either bedaquiline or linezolid. Now, in recent years a new term has emerged that is not universally accepted and is called TDR, which stands for total drug resistance. This term is not recognized by WHO yet. It has been reported from Italy, Iran, India, and South Africa. TDR is defined as any MDR strain that is resistant to all known first and second-line anti-tubercular drugs. There were 450,000 MDR TB cases reported in 2021 alone. Also, COVID-19 was a setback for the TB control programs globally. Now, post-COVID, the TB numbers are rising again, which is a real cause of worry for all of us. The emergence of multidrug-resistant TB cases has definite global impact and consequences. MDR TB has higher mortality in comparison to drug-sensitive TB. It requires prolonged treatment for up to 2 years. The drugs for MDR TB have frequent and serious adverse events. It results in loss of productivity for patients and caregivers. Its management requires specialized facilities, skilled healthcare providers, and expensive medications, resulting in overburdened healthcare systems. MDR TB is also a global health security concern. Looking at the Ukraine and Somalia, where we have seen ongoing armed conflicts, we saw mass movement of millions across borders. Both countries have high MDR TB prevalence, and mass movement puts other surrounding countries in danger of the spread of MDR TB. At a global level, a comprehensive approach that includes public health, social, and economic considerations is required to tackle such concerns. MDR TB also has stigma and social impact. Stigma with MDR TB can be in the form of social isolation, discrimination, and mental health challenges. In many cases, healthcare workers may be reluctant to take care of MDR TB patients out of fear. There are many challenges for the underserved populations. MDR TB disproportionately affects the vulnerable and marginalized populations like elderly, malnourished, diabetics, persons living with HIV, drug abusers, prisoners, slum dwellers, homeless, migrants, and refugees. TB bacillus thrives in these weak links, endangering the others. HIV and tuberculosis also make a deadly combination. TB can accelerate HIV progression. HIV patients are more likely to be drug abusers. MDR TB is 3 times higher in drug abusers. If you are wondering how common is MDR TB among all diagnosed TB patients, Here are some stats. 3.6% among new cases are multidrug resistant cases, and among previously treated TB cases who come positive again, MDR is as high as 18%. This picture gives the proportion of MDR-TB among all new cases diagnosed in various WHO regions. Surprisingly, Europe has disproportionately high proportion, mainly because of high burden in few countries like Ukraine, Azerbaijan, Kyrgyzstan, Belarus and Russia in Europe. Similarly, MDR-TB proportion among previously treated patients is also high in the countries mentioned above. This picture shows the burden and the number of cases in each country. The countries with bigger dots have highest numbers. For example, India has a very big dot. This is mainly because of the high population density in these countries. Some factors that are responsible for rapid spread of MDR-TB include incomplete treatment of drug-resistant strains, providing them selection advantage over drug-sensitive strains and allowing them to proliferate and spread freely. Other factors include overcrowding, poverty, drug abuse, and HIV. In this image you can see countries grouped into those having high TB burden, high TB plus HIV burden, high MDR-TB burden, and those having all three. This is a list of countries that have highest incidence of MDR-TB per lakh population in that country. What are the diagnostic challenges with MDR-TB? Microscopy cannot diagnose whether the TB bacilli seen under the microscope are resistant or sensitive forms. Culture is needed before testing for sensitivity, but it takes several weeks for the TB bacilli to grow in media. This causes delay in diagnosis of MDR-TB. Also, because of delay in diagnosis, most MDR-TB patients are put on first-line drugs for TB, which gives drug-sensitive strains selection advantage to proliferate and spread. The recommended method for diagnosis is culture and drug sensitivity testing. Using phenotypic methods, we can observe growth of TB bacillus in presence of antibiotics. But it requires biosafety level 3 labs to do this. Turnaround time for these tests is weeks to months and are not available in resource-limited settings. The other option available is molecular diagnostic tests for MDR-TB. They include gene expert assay and line probe assay. Gene expert assay is a molecular test that detects presence of TB bacillus in the patient's sample. It can simultaneously detect resistance to single drug, that is rifampicin, with a turnaround time of 2 hours. Minimal laboratory infrastructure is needed to perform this test and can be done in peripheral labs without biosafety. Line probe assay, also called LPA, is another molecular test with turnaround time of 2 to 3 days. It detects TB as well as resistance to two drugs that are isoniazid and rifampicin. Second-line LPAs can detect resistance to second-line drugs. This test is suitable for resource-limited settings, and it also doesn't need a biosafety lab. Other upcoming advances in diagnosis of MDR-TB include whole genome sequencing, next-generation sequencing, use of artificial intelligence, machine learning in diagnosis, microfluidics, lab-on-chip technology, and biomarker-based diagnostics. Once the diagnosis is made, then we have to face the treatment challenges for MDR-TB patients. There is limited availability of second-line drugs, especially in high-burden countries. The treatment is prolonged up to 2 years and involves complex regimens. It increases healthcare costs and puts immense burden on healthcare systems. Various hospital resources needed for the care of MDR patients include isolation wards with infection control practices which are non-existent in the high-burden countries, access to specialized expertise like infectious disease specialists, pulmonologists, and nutritionists. These are the various groups into which medicines for MDR-TB patients are divided. The drugs used are not devoid of serious adverse events. This list gives the ranking of various drugs used for MDR-TB and the incidence of serious adverse events caused by them. Some promising treatment regimens for MDR-TB include BPAL regimen that contains bedaquiline, predominid, and linezolid. This is a short-duration treatment for just 6 months. Most regimens for MDR-TB involve prolonged injection treatments. BPAL is an injection-sparing regimen which is a big relief for MDR-TB patients. Some strategies for prevention and control of MDR-TB include timely and accurate diagnosis by developing effective diagnostic tools. This should be complemented by development of new drugs and vaccines and adherence to the treatment regimens. Some new drugs developed for MDR-TB treatment include bedaquiline that acts against the ATP synthase enzyme in TB bacteria, disrupting their energy production. Delamana that targets the mycolic acid synthesis pathway in TB bacteria, disrupting their cell wall structure. Next is pretamina that is used in a novel 3-drug regimen, vidaquilin, pretaminid, and linezolid, known as the PUL regimen. Succinylate is another investigational drug with potential for treating MDR-TB. These 2 vaccines are under investigation for preventing TB, including MDR-TB. Despite all the challenges posed by the spread of MDR-TB, some countries shown here have demonstrated that progress against MDR-TB is achievable through innovative strategies, strong healthcare systems, and collaborative efforts. The future of fight against MDR-TB involves sustained efforts and research towards the goal of TB elimination. To conclude, MDR-TB is an escalating global threat with high mortality, prolonged and costly treatment. It affects vulnerable populations disproportionately and has become a global security concern. It has a difficult diagnostic process and limited treatment options. Fight against MDR-TB requires global funding, sustained efforts and research collaborations at global level. Hope you like this video. Thank you for patient listening. Like, subscribe, comment and share my videos. Do not forget to press the bell icon to get notified of new informative videos.